Welcome to this explainer. Look, if you're gearing up for your surgical or dental exams, you are in the exact right place. We're going to jump right into the clinical features and management of oral cysts today. We're keeping it strictly to the high-yield facts, the objective clinical features, and the professional review you actually need to confidently diagnose and treat these presentations. The goal here is to make these concepts really stick. So let's get ready to sharpen those clinical pathway for today. 1. Cysts in the mouth. 2. Mucus retention cyst causes. 3. Patient history and symptoms. 4. Clinical examination findings. 5. Surgical treatment options. And 6. Understanding the ranula. Moving right along, Section 1. Cysts in the mouth. So, getting the big picture right is basically step 1 in any diagnostic framework, right? According to our source, there are 3 primary types of cysts found in the mouth that we actively need to be aware of. We've got the mucus retention cyst, the ranula, and the sublingual dormoid. Now, while it's absolutely crucial to know all 3 exist, our source material, and honestly our main focus today, heavily emphasizes the first 2. That's the mucus retention cyst and its specialized variant, the ranula. All right, Section 2, mucus retention cyst causes. Let's really dive deep into that mucus retention cyst. We've got to start with the etiology, the cause. The key here is just understanding the anatomy. The inner surface of the lips, and really the whole inside of the mouth, is packed with these tiny, small mucus-secreting glands. And the cause of these cysts is actually surprisingly straightforward. It's quite literally just the obstruction of the duct of a single one of those tiny glands. When a duct gets blocked, the mucus just has nowhere to go. It backs up, it accumulates, and bam, you get a mucus retention cyst. And because of how those glands are distributed, this can happen literally anywhere on the mucous surface of the mouth. Which brings us to Section 3, patient history and symptoms. So, moving from the structural cause to the patient's actual perspective, what are they going to tell you when they walk into your clinic? The classic presentation here is super distinct, so you'll want to memorize this. First off, age doesn't matter. This can happen at literally any age. The main complaint you'll hear is usually about a, quote, small lump on the inner side of their lip or cheek. They're going to tell you it's a painless swelling and that it's been growing pretty slowly over time. Crucially, though, because of where it is, it gets in the way. They'll often complain that it interferes with eating or that they just accidentally keep biting it. Next up, Section 4, clinical examination findings. Okay, time to put on our clinician hats. This really beautifully illustrates the difference between what a patient feels and what you, the professional, actually measure. The patient just feels this annoying, painless lump that gets in the way of their dinner, but your clinical findings, they need to be highly specific. You are looking for a spherical, smooth, mobile mass. Usually it's going to measure somewhere between 0.5 and 2 centimeters in diameter, and you'll most commonly find it right there on the lower lip. Let's break down those visual and physical characteristics a bit more, because this is absolute high-yield exam gold. Location is a massive clue. It's super common on the lower lip and inside the cheek, right at bite level, exactly where the teeth meet. Now, what about the color? Usually it's a pale pink, kind of matching the surrounding tissue, but the fluid inside gives it this very specific gray, glary appearance of mucus. But wait, here's a great clinical pearl for you. If the patient has been biting it and damaging that epithelium, it's going to look white and scarred. When you actually palpate it, you'll feel a smooth surface, it might feel soft, or it might feel hard. That completely depends on the fluid tension trapped inside. Now, interestingly enough, our text specifically points out what clinical tests actually won't work here. Typically, if you see a swelling, you might immediately jump to a fluctuation test or a transillumination test. But our source makes a strict note that for a mucus retention cyst, these tests usually just cannot be performed. The cyst is simply too small. You will, however, definitely notice its mobility. It's mobile, meaning the overlying mucous membrane is not fixed to the cyst itself. Oh, and a totally vital negative finding to help you rule out the really scary stuff: local lymph nodes. They are totally normal. They are not enlarged. Moving on to Section 5, surgical treatment options. All right, so you've taken the history, done the exam, and you've nailed the diagnosis. Now what? Well, the source material is incredibly definitive on this next step. It plainly states that complete excision of the cyst under local anesthesia is the absolute treatment of choice. Write that down. It's the gold standard answer you want for your exams, and honestly, it's the primary approach you'll be taking in your actual clinical practice. But being a good clinician means being adaptable, right? The surgical approach has to scale appropriately. While complete excision under local anesthesia is the standard, if that cyst is particularly large, the text does note that general anesthesia might actually be required to make sure you get a complete excision. Plus, the source explicitly mentions an alternative: cryosurgery.
it says cryosurgery may be tried if possible. So it's always good to have those alternative tools sitting in your clinical toolkit.